spine is a common area where we have metastases, and how we can possibly help our patients who maybe don't do well after radiation treatment and still have painful mets and possible fractures in the spine. So here we have, in this case, we have the Medtronic device and other devices as well out there in providing a tumor ablation for painful metastatic lesions in the vertebral body. The device that we have here is actually an osteocool device where the tip of the actual probe is cooled so that to help prevent, and it circulates water through the tip of the probe so that to help prevent charring from occurring and help provide a more thermal sink and help provide a nice lesion. As you see, there's two probes there pictured, and we'll have that going, and it's going right now. And as you know, tumor cells, cells are killed at 55 degrees Celsius. Here at the distal portion of the thermocouple is at 70 degrees Celsius. Right at the middle portion of the probe, 90, and at the proximal thermocouple, 70 degrees Celsius. But we'll have that going and show the type of lesion that can be created by having the probes on both sides, and a nice elliptical type of lesion can be created to help target the lesions that we have.
So you can see that actually changing color. Is that a piece of chicken?
It is.
Okay.
That's a different chicken that we had for lunch, but it's creating a lesion more so on the right side than it is on the left, but
yeah, you can definitely
left is slowly coming in there as well.
Yeah, that's nice, Glenn.
So then we'll move forward with, here I have Dr. James Ying, my fellow here, and have Greg from Medtronic, Greg Majowski. Hi, Greg. So we're looking at some of the pearls for thoracic kyphoplasty as well. So we're looking at a transpedicular approach. All right, James.
So Lee, can we switch? There we go.
Let's switch over there, and we'll come back to that lesion in a little bit here.
So James, don't let Glenn steal that case from you.
Picture there. Picture. So yeah, I talked about a transpedicular approach. So as we know, for the thoracic spine, the lower thoracic spine pedicles are more situated similar to the lumbar, but as we get higher and up, higher through the thoracic spine, the pedicles are higher up, they're smaller, they're more sagittally oriented, so which poses some problems for kyphoplasty or for tumor ablation probes, because we want the actual probes and needles, and in this case, introducer, to be more medially oriented. In this case here, Dr. Yang going over just a transpedicular approach in the AP view here. I'd sometimes go to the more Scotty dog view to get right down the barrel of the pedicle. But here, we'll do the typical transpedicular approach. Good. As we're approaching here, going from at the 10 o'clock to 11 o'clock portion of the pedicle. We got of course, imaging is so important here. End plates are sharpened. You have equidistance from the medial portion of the pedicle to the spinous process. Dr. Yang, go ahead.
Shot, please.
He's entering there. As you see, we've matched one on the right side, already placed. He's going to enter into the halfway portion, halfway through the actual pedicle. And here, let's get a lateral view now. So we really, at this point, we should be looking at the lateral view to be safe. We want to make sure we are halfway through the pedicle. Want to get a true lateral, making sure the pedicles are lined up and the end plates are sharpened. Let's see. Here. Okay. So in this case, although it's safe, we're actually going fairly lateral, right? Yeah, we use double tip in this case, and maybe back it up, because we've entered the actual vertebral body, so we're going fairly lateral, so we'll back it up and provide a little more, double tip there. Just give you different introducer tips to provide some direction to the actual introducer. Let's back it up, James.
Okay. Victor?
And instead of a lateral approach, a little more medial. But let's now go back to the AP view again. Thank you very much. That's a little more medial, yeah. This way, yeah. The picture there. So, more left. Maybe just a tad more. Okay, let's go back to a lateral view. And the picture there. Still probably a little more lateral than we would prefer. Okay. Okay. All right. So Dr. Yang would then use the biopsy tool to kind of core out from the bone there. Just watch the end plate and watching all, we'll see the anterior cortex picture there. That's good there. Backing it up. Sending the core for biopsy, pathology. And then using a drill also to help core it out to provide room for the probe for tumor ablation. Picture there. And then after that, the balloon. Good there. We'll pull that out. Then we actually, I'm going to show the audience. So this is a curette from Medtronic company. Other devices that out there help just to core out the actual cavity area before the balloon is placed to help provide a little more room for the balloon to, and provide possibly direction of where you want that balloon to be oriented. He's doing a lateral view in this case.
Picture.
And live. So you can lock it at a 45-degree angle or a 90-degree angle. I'll provide some cavity creation before that balloon's put in, and maybe you want to steer away from possible end plate fracture or area that you quite unstable or quite open. Oh, actually, 1 second. So at this point, we actually would use the probes. If you want to picture back the actual AP view of the chicken lesion we provide with the osteocool or thermoablation created by the 2 probes put in. So we're looking at with these 10-millimeter balloons, we're looking at a 19 millimeter AP length and width of approximately 29. So nice lesion created there. And so at this point in our procedure, we would actually put the probes in, wait the approximately 2.5 minutes where it's actually put in and the ablation, and then we proceed with doing the actual balloon kyphoplasty. Go ahead. Actually, move forward with the actual balloon. So what are some of the end points for using the balloon? More of volume. In this case, a 5 cc is the actual volume we want to make sure we're kind of staying away from. And also in this case, the PSI we're looking at is a maximum of 700 PSI for this balloon, but other balloons, of course, will vary. And of course, we want to stay away from heavily from the end plates, as well as the anterior cortex, and looking at possible fracture reduction in some cases. Picture again. As you can see, it's getting closer to the inferior end plate, but keeping an eye on that a little more. Shot. Picture there. Okay, that looks pretty good there. All right. And then, of course, we retract the balloon. And then looking at the cement. Right now, we have cement going at this point. We're going to be looking at putting in cement at this level. Go ahead, James. First of all, you want to go down to 100 psi before just suctioning off the rest of that actual distilled contrast liquid, so you don't actually pop the balloon. So the alternatives for, at times, if let's say you went in a uniparticular approach, a lot of the different companies, in this case, Medtronic has this curved introducer to help get the cement over to the other side. And if you see, as you come in, do you want to get that one in? Help provide cement to the other side if you went in a uniparticular approach. Let's have a look.
So, Glenn, do you normally do, on thoracic, do you do bilateral then? Or do you try to get across to the other side?
We try and get across the other side. If we're going to be doing a tumor ablation, we do try and get onto both sides, depending on where the lesion is of course, though. Mm-hmm. This is back up there. Excellent. And let's look at their AP view and see how much that has gone across. So a lot of the different companies will have devices like this. Other companies will have devices where they have curved needles to get across in this fashion as well. The other companies will have devices where the ablation can be curved and turned, the needle turns, and the ablation can be done across the actual vertebral body as well. So you can see it's come across quite nicely. Then we can deliver the cement in this fashion. James, you want to go ahead and deliver the cement? So things that I'm looking for in delivering cement, and what is the consistency of the cement. Of course, make sure it's not sticking to my glove, making sure that the actual cement itself is no longer shiny. So it's not sticking to my glove, of course. The shine of the actual cement is not there any longer. Kind of a thickened silicone cement there, which is nice and safe for our patient. It helps decrease the extravasation. Thank you. All right, Dr. Ying's going to deliver that cement. But we're going to go to lateral view if we could just have an actual C-arm. But if you have biplanar, it'd be great. But in this case, let's get the C-arm into the lateral view, which is a safer view to lateral view, please. Thanks. Go ahead. Picture. Picture. And slowly coming out there. Picture. And slowly but surely coming out there. I think you guys get the idea. Nice controlled delivery of the cement.
That's great, Glenn. So do you try to put it about 1.5 cc's?
It really kind of depends on the fracture itself and the area, and as well as if we're trying to get some fracture reduction as well.
James, can you tell, is it getting more difficult, or is it the same?
I think the cement's getting thicker as we...
So the delivery, what's the working time for this cement? 16 minutes, okay. Mm-hmm. And
do you want to try to do the other side as well?
Yeah, we'll do the other side as well, but I think, sake of time, Dr. Abdul-Jabbar did a great job of displaying the different cements and areas of actual levels for cementing. But so that is the transpedicular approach. So if we go back to the AP, I'll quickly go over the extrapedicular approach, just to get an idea. So, well, why would we do the extrapedicular approach? In those cases, higher up in the thoracic area, as you know, it's more sagittally oriented to get our introducer areas to more medially oriented to get the balloon or needles across. Maybe a better idea to use the extrapedicular approach. Let's go north to the upper thoracic region.
That looks great, Glenn. Good job.
Nice controlled delivery there. And we're going to have a view of our upper thoracic area.
Oh, wow. That's great.
So in this case, we have one already put in. We have the, on the left, in the extrapedicular approach, we're looking at getting it, just in between the superior articular process and the rib. So in between that and in the lateral superior area of the pedicle. Picture there. And picture. Picture. And let's get this other one in. So halfway through the actual pedicle, let's go lateral. In this case, getting more medially a lot faster because we're not going through the pedicle, going extrapedicularly. No problem. It's a little blurry there. I don't know. The sound. Picture there. And live. Yeah. So we enter already entering the cortex of the vertebral body, and we haven't passed through the medial portion of the pedicle, which is, an area when we're doing kyphoplasty, making sure we're not crossing too soon, and making sure we're already entering at the same time, or in this case, we're into the cortex sooner than we actually cross that medial portion of the pedicle line. Okay? And bring that in a little bit farther. And this portion, it's very similar to the exact same as the other one at the transpedicular, where we're coring out the actual bone, sending for biopsy, doing the actual drilling out, and with this company, and then actually doing the balloon or tumor ablation at that point in time, and then proceeding with the balloon and then cementing as well. That's the extrapedicular approach for thoracic kyphoplasty, a different approach that can provide some options to you with a more sagittally oriented upper thoracic pedicles. Okay? Rod, any questions? Can you hear me well?
No, this is great, Glenn. Thank you so much for presenting.
No problem. Thank you guys for having us.
Yeah. So, James, terrific. James took his vacation and switched it so he could be here. James, great job.
Thank you.
Glenn usually tries to steal the chase, so.
Thanks, guys, for having us, and great course.
Terrific. We really enjoyed seeing that ablation as well.
Well,
So,
let's see that last one with me. The last picture of the ablation. Let me see if it's changed at all.
so Glenn does all of our kyphoplasties, vertebroplasties, and he's really taken the procedure to a new level. In fact, he does such a good job that Jens and I are going to start getting back into it. He's doing too many. We're getting jealous.